All right. Well, I have been looking forward to this discussion for quite some time. My path crossed Dr. Ronald Caplan, and when I saw the breadth and focus of this book, the care for the older person, and that it was in its fifth edition, I did everything I could to try to get Dr. Caplan to come on and lead us in a discussion and help us learn more about this book. So I am going to stop sharing and welcome Dr. Caplan. Thank you for being here today.
Well, thanks so much for having me, Steve. I appreciate it.
Yeah, and before we dive into the book, let's get to know you a little bit better. Tell us a little bit about your background. And an interesting thing Dr. Caplan said to me before we jumped on here, he's like, Steve, how old are you? And I was like, well, I'm 57. He goes, oh, I got kids that are older than you. I'm 85 years old. And you know, you've been walking the planet a lot longer than I have. And so I am eager to learn from your wisdom today.
Well, first of all, we define the oldest old as 85 plus. So I have now joined the ranks of the oldest old. And that gives you, as you said, something extra, which is that at this point, I not only am current in medicine, but I represent a lot of the history of medicine. I'm a product of two major universities. Well, I'm a product of my parents, of course, but I'm also a product of two major universities, McGill University in Montreal, Canada, and Cornell University, of course, here in New York City. When I started at McGill, well, they took me as a kid and made me into a doctor. And then they made me into a specialist. And in my latter years at McGill, we got interested in renal disease and pregnancy. And as a matter of fact, it was the early days of renal transplantation. And I actually delivered the first baby ever delivered of a woman who had a renal transplant from a donor who was not living, who had been deceased. And we went on from there. Actually, it was just before, well, I left Canada in about 1970, 71, but there was a big World's Fair in Canada, Expo 67 in 1967, and there was a famous theater in it called Medi Theater. And the opening sequence in Medi Theater on these multiple screens, and which was then state of the art, was me delivering a baby, an Rh positive baby, healthy from an Rh negative mother, which was real breakthrough in those days. That was seen live, well, live in the theater, but I was on film by 2.5 million people. And in those days, nobody had ever seen a delivery except doctors, nurses, midwives. So 20,000 people fainted, is what I heard.
Wow.
In any case, then I went over to Cornell University, where I stayed for most of my professional career. And I got involved in, I was one of the early proponents of minimally invasive surgery, up to and including microsurgery. And I am now clinical associate professor emeritus of Obstetrics and Gynecology at Weill Cornell Medical College and Cornell University. And I think my philosophy here is keep going, okay? So I have always kept active in writing. This is at least my third major textbook, and there have been a lot of mass market books as well. this book is written on the philosophy that older people should be cherished and respected. And more than that, medical care is not something in a vacuum. In other words, how a person does has a lot to do with everything around them, their entire environment, and what they do for themselves, not only what their doctor suggests.
I love it. This is amazing. You've had an amazing career, and we're lucky to have someone with your expertise and wisdom focusing on older adults. And let me share my screen here, because I dropped into chat a flyer with a 20% discount code on the book in case anybody would be interested in ordering it. When you're on that flyer there, you can click on this link and go direct to the publisher's website where you can order it. Okay. But one of the reasons I wanted to go here is because we've got the table of contents, and Dr. Caplan, a lot of times when we have authors on these discussions, I'll pull up the table of contents and we'll go through each chapter, because there's only 5 chapters. Okay. But I want folks to sort of see the breadth of this book is that this is, let's see, how many chapters do we have here? We are at 46 chapters. Chapter 46, the role of religious belief and end of life, and cancer screening for older adults. Could my patient be a risk of orthostatic hypertension? There's just so much in here. Let's dive into, first off, this book is in its 5th edition. When was the first edition published?
First edition was 6 years ago, approximately, when it actually came out. It was conceived a little before that at a formal meeting between me and 6 senior faculty at McGill University, including the former Dean of Medicine, Abraham Fuchs, and the Chief of Geriatrics, who was Jose Moret, and all the others are top-level professionals who are experts in various fields. Most of them have actually written 1 or more chapters for this book, but this book has now been written by international experts. So we started off with, like you say, a small handbook, which a doctor or any professional could slip in their lab coat pocket, or anybody could use at home for a quick reference, into this comprehensive textbook, which people could peruse at their leisure and find exactly what they want to know about, and go from there.
Yeah, and let me go back to the table of contents, because I think I've got a way that we can kind of tackle this in a meaningful way. So the 49 chapters are grouped into several different sections. And so you've got helping, you've got vulnerability, you've got caring, you've got cancer, you got considerations, and you've got understanding and protecting, and then a glossary of medical terms there.
Right.
So,
the table of contents became so big that I decided to divide it into sections. I tried to name those sections according to the things that we want to feel and about older people: helping, caring, understanding, and then specific items such as cancer, which is a subject unto itself, like a lot of other subjects. To start with the beginning and the end, okay, that follow the philosophy. we start off with an introduction that talks about how the science, as it goes to aging, is progressing by leaps and bounds to the point where we don't even like to talk about it yet because it's really not doable yet, but the reversal of aging. And that's the theoretical end. If the next chapter by Abraham Fuchs, who I mentioned before, talks about the caring, what you should really be doing with patients in a broad view. And the very end chapter, and I purposely put it at the end, is to make professionals and caregivers who deal with older people know that you should respect the religious beliefs of who you're dealing with, right?
Or lack of religion.
The person you're taking care of, or lack of religious belief. And that's brought up too. But the underlying thing comes out in like the last 3 or 4 sentences of the book, where the author of that chapter says that, and what most people don't realize today, and especially in a secular society like ours, is that most of the people on earth today have a religious belief. So it doesn't matter if you have that religious belief, if you don't have that religious belief, you need to respect that religious belief. Mm-hmm. And everything in between we get into really technical stuff like transplantation, and we get into ethical stuff like, well, okay, say a very old person like me, for example, 85, needs a transplant. Now, there's waiting lists of donors, right, for donors. And all these people who need a transplant of a kidney, a liver, a lung, a heart, all these people need to be prioritized, right, in some fashion. And how do you ethically do that? And how do you ethically supply an organ to be donated to somebody like me who has a rather limited life expectancy? Although theoretically, and again, this is very theoretical, you could live to 137. Actually, I think the oldest living person ever recorded was 122. And right now there's some 118-year-old people walking around. But it's no longer uncommon to be 100 years old. Most of the people who are 100 years old are women. And we go into various reasons in the book why women tend to survive longer than men. And the bottom line answer is we really don't know why, but we have a lot of good theories, or theories anyway. So the purpose of the book is to make life more meaningful for older persons, and if possible, to make their meaningful life longer, which is also possible by a lot of the things mentioned in this book. So that's where we're going.
I love it. And I also love it that Suzanne has already hit us up with a question. And this is a reminder to everybody that use chat, use the Q&A, and let's have a conversation. And Suzanne's question says, I'm interested in the eating habits of older adults. My mom does not have an appetite, and it's hard to get her to eat. And I noticed here on the table of contents that you have a whole chapter written by Heather Lambert, Eating, Drinking, and Swallowing Problems of Vulnerable Older Adults. Any thoughts on this, Dr. Caplan? And then I also want to bring our other audience members in. If you've got some solutions for Suzanne, feel free to drop those into chat as well. But any thoughts on eating habits and solutions there?
Well, Heather Lambert, who is a therapist, pretty renowned. She runs the program at McGill University. And this is a very comprehensive chapter. So without getting into a lot of the details, there are certain things you have to know about older people and their difficulties, which start from difficulties in swallowing. And then, of course, you don't want them to aspirate. And she goes into all that. And she talks about restaurants and how older people are probably better off not in very noisy restaurants. And a matter of fact, what you were alluding to before I came on, the thing about hearing aids next week, we have a whole chapter by Dr. Montano, who runs the program at Cornell University, and he makes the point that hearing loss is the invisible condition. You can't meet a person while they have hearing loss. So he gets into all the things that could happen with hearing loss and all the defense mechanisms. And so what you're doing next week is very important as well, I want you to know. So the thing where that ties in is a noisy restaurant with a person with some hearing loss, irrespective of they have good digestion and they can still properly swallow. A noisy restaurant is impossible for a person with hearing loss, although there are techniques today. I mean, you have your hearing aid plugged into your cell phone and you can put on the restaurant application, but if the restaurant is noisy enough, believe me, it's not going to help you. So Heather Lambert talks about a quiet, nice environment for the person who's eating, and if they need a therapist with them, exactly what kind of foods they should eat, what kind of liquids they should drink, and how this should be given. Dr. Montano talks about how when you're talking to an older person, speak to them to their face. Instinctively, interestingly enough, what he brings up, I've learned a lot from this book, I want you to know.
Oh, yeah. That's why I like having these discussions. I learn something every single time we have one of these. And here, this is great, Dr. Caplan, because our audience members are sharing some interesting solutions for Suzanne's question. Jean Marie says, you may find that your mom might respond to offering foods that she wouldn't expect she would like. My mom suddenly started liking spicy foods. I took her to a very quiet Korean restaurant 2 weeks ago. And then Abby adds, it's also not uncommon for older adults to have decreased appetites and loss of taste and or smell. You can offer small, frequent meals that are dense with calories, heightened flavors, foods that the person really enjoys. And it's also not all older adults have swallowing problems, dysphagia, but some do. And sort of pinpointing, where that is. Another thing, since I've got you on as a doctor, and another solution that I've heard through some of our community members is that with medical marijuana, where sometimes an older adult may lose an appetite, I have heard anecdotally that that can be an appetite enhancer. What are your thoughts on medical marijuana for older adults?
I think it's fine. The real reason for marijuana, in my opinion, is that people like it. Okay. And then the ancillary things come along, like, well, maybe it's good for your appetite and maybe it has some medical uses. It certainly changes your mood. so the big problems with marijuana that will be seen now that it's legal in huge parts of the country, even for recreational use, is the impairment thing, like driving a car or doing some professional activity. For example, being a surgeon. You don't want your surgeon to be high, I don't think. I think you want him to be happy, but I don't think you want him to be that happy. So there are downsides to it too, but yes, traditionally, marijuana helps with appetite.
Yeah, one of the person that was telling me what she and her practitioner did was they put just a little drop of oil on a mini marshmallow, and that's how she takes it, and it enabled them to administer a dose to dial in the dose for her. Jean has a follow-up, and she says, I'm here with my mom today. She just met her new primary physician today. He mentioned that vision and hearing is easily prevention to dementia. My mom also is concerned about what she eats because of GI issues. And she also says, funny, she's not hungry, and then she eats everything on the plate. It's like she has a script in her head and it doesn't reflect the reality. So Jean, thank you so much. And hi, Mom, if you're listening, for sharing those. And I'm really delighted to see other attendees offering some solutions to your mom's problem. Let's see. This is going back to your book, Dr. Caplan. Emily says, I'm trying to use the discount code with Amazon for ordering the book. It's not accepting it. Okay, so
it won't work with Amazon. You have to go directly to Routledge to get the discount.
Yeah, so I'm going to go ahead and I'm going to drop the flyer into chat again that has the discount code, and you need to go to the publisher's website, okay, with discount.
Right, that'll work.
Okay, and let's see. I knew this was going to happen because whenever we have a healthy, vibrant, 85-year-old who's very transparent, we always get questions like this. And Sherry says, so what is your daily routine? You look great, and I assume your physically well-being is the same. I have a 95-year-old client who simply says, well, of course, I want to live as long as possible. Do you think the dialogue of the whole Today Show's Smucker's marketing, the 100, centenarians is a good idea? But let's break that down. Sherry has several questions there. Tell us a little bit about your daily routine. What do you do to keep healthy as a doctor?
Well, I think, I try to practice what I preach. I think you have to be lucky because from in the year that I was born, which was 1937, if you projected out my actual life expectancy, it would have been 72, maybe. You got to be lucky. You have to have good genes. Look at your parents. How long did they live? You have to stay out of trouble because along the way in a long life, things happen, wars happen. Then people get into car accidents a lot. So all these things that happen to younger people obviously don't let you live to a ripe old age. Now, some of us who've gotten this far, we all have our battle scars. I've been in a couple of bad car accidents. younger. I had an appendectomy when I was 11 in 1948. If you could imagine, such a thing was a big deal then. If it would have been 20 years before that, I might have died. So, you know, I had childhood diseases that we didn't have vaccinations for. So you have to live through all that. And then when you get into your older years, then you have to start making specific plans and have specific ideas on how you're going to navigate the rest of your life. And one of the most important things is to stay active, physically and mentally. If you don't do that, even though you may live, you won't live that well. And the other thing that is so important is to keep social relationships. If you don't have people around you who care for you and even love you, it's tough. It's really tough. So it's very important to be perfectly frank. You get to be my age, and most of the people you dealt with in your life have gone to the great beyond. And you have to be, you know, I used to joke, but it's not a joke. Make younger friends. So, or you could make friends who have survived like you have survived. You could do both. And you should interact with as many people as you can and have an interesting life. Read, learn, even take classes. And if you're still active in your career, well, God bless you. That's wonderful. Just keep going. And as far as physically, you just have to. The most important thing for an older person is to keep mobile. Walk as much as possible. And then we get into the subject in the book, like frailty. And then we get into the subject of how you counteract frailty. And that's written by very good academic therapists who have programs to get people who are frail back to some kind of normal. So walking becomes a very good aerobic exercise, very good for you. It's very good for your mind. If you can still run, that's admirable, but it's high impact. And I used to run a lot, and I don't anymore because I can't. Running is wonderful for your head. It's horrible for your knees and your feet. So, you know, unless you have a really good trainer and you're doing it almost professionally, or you're competing, then you have trainers, you have physiotherapists, and I continuously recommend this in the book, that you need these things to keep you going. You need support systems when you're older. Luckily today, a lot of the support systems are the result of like what we're doing today, Zoom technology. I don't have to run to Washington to see Steve. I can do it from the comfort of my home, right? If I had to go to Washington, I guess I'd go to Washington, but it would become a whole planning thing. It's not so easy when you're 85 just to hop on a car or a bus or a train or a plane and go somewhere, you know, especially with the airports and all the rest of it. So you know, it's that kind of technology. You need technology in your home. You need technology with your doctors. I have a cardiac, it's not a pacemaker. It's just a monitor implanted under my skin. It's about that big and you can't see it. And my doctor at Cornell, remotely, has a continuous recording of my heart. And every so often I get a call from a nurse, or it says, you know, we looked at your record today or yesterday and you have thus and so, and increase your dose of whatever, or decrease your dose of whatever, or come in and see us, or, you know, So it's very comforting. And I'm not saying everybody needs it, but if you need it, your cardiologist will tell you, maybe listen.
I tell you, Dr. Caplan, you've literally in just 5 minutes, you've gone through probably every talking point that we've had over the course of the year. First talking about friendships and intergenerational relationships and building your network. I did drop into chat. Next week, we have a discussion on intergenerational play groups, but building your network before you need it, and having a wide variety, interacting with a wide variety of viewpoints. And the other thing that you've touched on too is technology. I mean, the fact that we're having this conversation right now would not have happened 5 or 6 years ago. We could have done it, but now we have access to make connections to people all over the world. And the thing that I want to kind of land on here is you were talking about frailty and also luck in terms of what how healthy we are going to be. Like, I mean, you could be healthy as a horse and do everything the right way, but then get in a car accident and all of a sudden you're not as active and mobile as you once were. But we need to be able to reinvent ourselves sometimes. Like you said, you used to run and you've given that up, but you've reinvented yourself to find other ways to stay healthy and purposeful.
Oh, you have to do that. We haven't touched on a big elephant in the room, which is Alzheimer's disease.
Thank you.
There you have to be lucky too. In other words, if you don't get it, great, right? We have 2 chapters in the book on Alzheimer's, written by one of the world's foremost experts on it, who was Serge Gautier. We don't know the answers to it yet, but we're starting to get glimmerings that there may be drugs in the offing which may help. And there's a lot of talk, you may have heard about it with the FDA now. So there may be something in the future. It's interesting that with Alzheimer's disease, there's deposition of a substance called amyloid in the brain. And I go back to one of my colleagues in medical school, who became one of the world's experts on amyloid. And I mean, we don't know if amyloid is cause or effect, but it's there and it's not good. And now we know, which most people don't know, is that you can get amyloid in the heart. So, the science evolves, and there's a lot we don't know, but there is a lot we do know. And I think we can be proud that we expanded, extended the age to which people expect to live and should live substantially. And that was going up every year till a couple of years ago when we hit the COVID epidemic, which we also go over in the book. And what one of the key points is, and we get to that in the COVID chapter, and then we get into it in the architectural chapter, is the whole nursing home issue. And we have an absolute top level architect, Julia Gersowitz, who's been honored all over the world for her work. And she comes up with some really interesting proposals on how people should live and how architecture influences that. Basically, as long as you can, and you have the support, and you have the technology around you, and you have your good doctors, if you could be at home, you're in the best place. That's our basic thought. But if you have to go into a nursing home or some kind of place like that, we want them redesigned. We want them rethought out. We want the staffs to be super educated. We want them, they could start by reading a book, but they really should know what it's all about. And they should be caring people. You should be careful who's taking care of your older loved one. It should be somebody who cares. So that's pretty basic, I think.
Great. Well, let me get to a few more questions that have been rolling in here. Sherry has a follow-up to the device that you're using in your heart. It says, so you have 0 big heart issues and it's not a pacemaker. What is the device you're used for?
Well, these are for heartbeat irregularities. You know, I have something called ventricular tachycardia, if you want to get very specific. So that's relatively common. And there's a few other little bells and whistles that go with that. And that's what the doctors are looking for when they read the remotely sent EKG.
That's great. Okay, let's see. Jennifer Brown says, low-dose cannabis tablets. Cannabis is known as an appetite stimulant. That was back, Suzanne had a question about appetite. And yeah, I believe that's the other thing is that now that cannabis is being used, that the way that we administer it, there's a lot more choices. So what I was talking about with the marshmallows, you may be able to buy a product with a low dose now, and it sounds like you can. And then Kelly Lambert says, the issue is that some elders no longer drive and rely on somebody else to pick them up, something that might appeal to them. Lack of energy to prepare food can be an issue. Lastly, many elders have been told by their physicians to avoid salt and sugar. Oh yeah, yeah. I mean, there's a lot of when we look at somebody and they're not eating, there could be a lot of other contributing factors here, as Kelly outlines.
Well, there could even be. We have a chapter on dentistry, and the dentist who wrote the chapter goes into, you know, it could all start with your teeth. I mean, if somebody is having problems eating, they need a dental checkup for one.
Yeah, and again, this sort of stems into the topic of affordability. We have millions of people in our country and millions of older people in our country that are making the choice between living and their budget and medical care. And as we all know, a lot of times dental care is not appropriately covered on insurance policies. And I'm not sure where dental lies in Medicare, but you're right, Dr. Caplan. For somebody on a budget, that could be a contributing factor too, is that they haven't had proper dental care.
Oh, absolutely. What you just brought up is so important. First of all, the number of people 65 and over in this country alone is 50 million. That's a staggering number. And this is not people who could, they're even with specialist physicians, geriatricians who take care of this kind of thing. There's no way on earth geriatricians could take care of 50 million people except in a supervisory capacity. And that is why we get into caregiving goes all the way from the geriatrician all the way down to the person on the ground. And that person on the ground is a healthcare worker or a family member. And that's who needs to know a lot of information so they can take proper care of a person. And yes, the economic considerations are enormous, especially when you're in an economy where there's inflation and people are on a fixed budget. You know, this country spends trillions of dollars a year on healthcare. By far, we're the biggest spender on healthcare of any country on earth. And so there's a lot of options here, but then again, like you say, there's also a lot of obstacles.
Eileen has a question. What is your opinion on NAD supplements? Do you recommend any supplements? And I had to look this up. NAD stands for, oh boy, NAD, I saw it here, nicotinamide adenine here, I'm just going to drop that into chat. But what are your thoughts on NAD supplements, or do you have them? And what are your thoughts on supplements in general?
My thoughts on supplements in general is that they're overused and unneeded in most cases if you have a proper diet. Now, that's a big if for most people. And the person to talk to about that is your physician, your dietitian. Those people will go over your diet with you, and if something's lacking, then they'll give you the proper supplement, whatever it is you need. For instance, older people, more women than men, need calcium supplementation, for example, and not forever, but for specific periods of time, again with the advice of a dietitian, physician.
Great. Yeah, so it's really funny when we do these discussions, the rabbit holes we go into, and I never would have imagined that we would be talking so much about diet on this discussion today. But I'm glad that we're having these conversations and sharing these thoughts and ideas. And Gene,
well, it's important, and we do have a very comprehensive chapter on what older people should be eating, as well as a chapter on diabetes in older persons. By the way, we use the word persons rather, you notice we call the book The Care of the Older Person, not the care of the older patient. We're trying to emphasize we're dealing with people here.
Mm-hmm. Yeah, one positive thing is the language that we use for all individuals has improved radically in the last decade, and our sensitivity towards how we communicate, especially to older adults, is very important. Gene says eating boring food is boring. I couldn't agree more. And I think the byproduct, and somebody had mentioned that they took their mom to a Korean restaurant. Eating is not only for nutrition, but it's really one of the primary ways that we socialize. And so that's probably why we've gone down this rabbit hole quite a bit today. Let's see. This is another great comment from Gene. We've also deferred food preparation and have lost some of the joy in preparing food from basic food groups. But Gene, we were talking about senior living communities, nursing homes, what have you. One of the downsides of those settings is that you take somebody who was in their home and they were involved in preparing their meals, and that's a purposeful activity. And then you move to a setting where we say, oh, you don't need to make your meals anymore. We do all that for you. We bring it to you. If somebody found purpose in washing the dishes every night, and now all of a sudden you've taken away from them, a lot of times they can't put two and two together why they don't feel like they're living a purposeful life.
That is also important. And a word to the wise about cooking: get to know a good cook. It helps.
Well, especially one of Dr. Caplan, our number one topic on these discussions is solo aging, is people who are living alone and they never expected themselves to live alone. And on the topic of eating and food preparation, if you were in a marriage or relationship where your loved one cooked all the meals and now that loved one is no longer there, it can really impact a lot of your life. And this is where a lot of our discussions on solo aging are, A, if I don't do this, how can I learn how to do this? But B, mapping out a plan and sharing some of these responsibilities with your partners so that if they're no longer here, you are able to still live that purposeful life.
Or if they're incapacitated, you could help them.
Yeah. Let's see. Okay, I'm got some great comments and questions coming in. Kathleen says, after oral cancer, I needed to replace teeth on the side where I still had teeth. The cost of a single post and a crown is $6,000 total. Dental plans require 1 year before an implant is 50% covered, plus one is restricted to the dentist to accept the plan. Yeah, I mean, these are real life problems. And even if you have accumulated wealth, an investment like that can be very significant to a budget.
Oh, it could be devastating.
And let's see, Emily says, thank you. And those living with dementia outside of the medical sites are not Alzheimer's patients. Yeah, yes. Okay. Kathleen says, a guideline I read for what to eat: don't eat anything your grandmother wouldn't recognize.
Now, there's a good idea, except there's good and bad in that, because we fondly remember all that cooking, but I remember it. I'm old enough to remember that kind of cooking, and sometimes we ate too much, and sometimes we ate things that were very high in cholesterol, and it wasn't all great. I eat very differently now than I ate when I was a kid. I guess we all do.
And Janina has a really good point, because we talked briefly about what could be better in senior living and nursing homes, and we talked about, hey, if you can age in place, that's the preferred place to be. But one thing that I have discovered, especially with the pandemic, is if you are lonely and isolated in your own home, if you're not eating properly, and if you're not engaging with other people, that's a great reason to do some research to look into different living environments where you can have that engagement. And she mentions that, hey, a senior living community that has 3 meals a day and it's easy to get a healthy, nutritious food with other people could be an ideal decision.
Well, it's not either or. Thankfully, today there's all kinds of gradations. There are active adult communities. These are for people 55 and older who are active. They don't have any particular health problems of major significance. And yes, they could live there forever and sort of grow into it. And there's facilities, but they're still in their own home within this community, and they can socialize, and there are central meeting halls, and there's sports events. There could be a swimming pool, walking trails, all kinds of things. And that is like a first step. And then you go on there all the way to people who say, unfortunately, have advancing Alzheimer's and need to be in some kind of a nursing home situation with a lot of help. But those places don't have to look like hospitals or jails.
Exactly. And I think thank you, Janina, because I think that really frames the discussion. And what you said is that the advantage is that you have choices, is that and one size does not fit all for everybody, and make sure that you you or your loved ones research those choices and talk to different people about that. Wow, I just glanced at the clock and it looks like we are getting close to the top of the hour here. So Dr. Caplan, we've talked about a ton of stuff. I'm dropping the book, the discount code and the link back into chat. But any sort of talking points that we didn't cover today that you kind of wanted to share as we wind down our conversation?
I think we've covered a lot, but just to sum up, I think that it's important that older people, and they're a huge percentage of our population now, are integrated into the population, into our everyday lives. They live among us and they work with us. And a lot of them still work, fortunately. And they're there to be respected and loved. Even if they think a little slower, give them a second. They have a lot of knowledge back there, and love them up. I think that's the key.
I love it. Dr. Caplan, thank you so much. And I would love to do this on a regular basis, because I think it was, we can go down so many different discussion topics with the breadth of your knowledge and the book. And I really want to thank the people that tuned in today, because you really make these discussions dynamic. And every time I turn one on, I'm sort of like, what are we going to talk about today? And great questions and comments today. And I hope that it was helpful to everybody.
Well, it was great being with you, Steve.
All right. Okay. Everybody have a great weekend.